Okay.
Hi, good afternoon and welcome to our webinar on Space Tool 2.0. And this is a downloadable Excel-based tool that you can use to look at the impact of changes in STI prevention budgets. And we're really excited to be here today to tell you about the tool and how you can use it in your work. And this webinar is being hosted by the Public Health Accreditation Board, a nonprofit organization that is the accrediting body for public health departments in the US. And during the webinar, we'll explain what Space Tool does, how it works, and key changes that we made in the new version that we released this past February. We will also talk about how you can access the tool and other resources, such as training materials on how to get started. And we also have a panel of prevention partners from Michigan, Vermont, and the National Coalition of STD Directors who will talk about the tool and how it can be used for STI prevention efforts. And for those who don't remember the SPACE acronym, it stands for STI Prevention Allocation Cost Estimators. So a little bit of housekeeping. All participants here are muted. We do have a chat feature, so please use that to submit your questions. We will have time to answer audience questions at the end. If you're not able to use the chat feature, please send your question to info@fabboard.org. And this webinar is being recorded, and we will send the recording to all participants along with other materials, such as where you can access the tool. And the last thing before we dive into the content is that, as a disclaimer, the SPACE tool and its underlying methods do not necessarily represent the views of the Centers for Disease Control and Prevention. Its use should be limited to estimating the impact of budget changes as described in the model documentation. And this work was funded by CDC and was done in collaboration with university researchers through the cooperative agreement that is on this slide. So to kick us off, I'm pleased to turn this over to Dr. Harold Chesson, who is a health economist at CDC and a familiar face to many on this call. And he's also been critical to the development of the original SPACE tool and the updated 2.0 tool.
Thank you, Erica. Hello, everyone. Welcome to the webinar today. And we're really excited about the SPACE tool 2.0, and it's really great to have you here. Also, I want to thank the Public Health Accreditation Board for hosting this seminar. Next slide, please. So what is SPACE Tool? SPACE Tool is a free spreadsheet tool that STD prevention programs can use to estimate the impact of changes in their budget. As Erica said, the acronym is STI Prevention Allocation Consequences Estimator because it estimates the consequences of changes in the budget. The tool is most suitable for states and for large cities, such as those cities that are directly funded by CDC for STD prevention. SPACE tool estimates the impact of budget changes on syphilis, gonorrhea, chlamydia, as well as the number of HIV infections that are attributable to these three STDs. So when there is a budget increase, SPACE tool estimates the number of infections averted and the medical costs that are saved. When there's a budget decrease, SPACE tool estimates the number of additional infections that we'll have and the additional medical costs that would be incurred. Next slide. So why was SPACE tool developed? The SPACE tool methods were initially developed almost 10 years ago here at CDC when jurisdictions requested guidance on how to estimate the impact of STI prevention program budget changes. Specifically, there was a colleague at the state level who had received a request from the state legislator about his concern about the increase in STDs, and the legislator wanted information on how much an increase in STD prevention funding might have in terms of an impact on STD rates. So I told this colleague that we have published studies that show that STD prevention funding does have an impact on STD rates. And working with that colleague, we were able to develop a response to that legislator's request. And while we were doing that, we thought these calculations that we're doing might be helpful for other jurisdictions as well. And that's how we decided to come up with the original tool. The original tool, many of you may remember, was named Space Monkey. We have since rebranded the tool, this to be Space Tool in response to feedback we've received in terms of coming up with a name that's more inclusive and acceptable to all users. There's two things about the Space Tool that I'm most excited about. First is that Space Tool calculates estimates based on the scientific literature. And what this means is that the estimates you get from Space Tool are evidence-based. And we provide a published study that you can cite that documents all of the calculations that go into Space Tool. The second thing I'm most excited about is we think the new interface is easy to use and enables public health practitioners to customize the results to their jurisdictions without needing expertise in health economics or economic analysis or mathematical transmission modeling. So I hope you are as excited about Space Tool 2.0 as I am, and I will turn it back over to Erica, who will provide a more detailed overview of the tool. Thank you.
Great. Thank you, Harold. So I am excited to talk to you about Space Tool 2.0. I led the scientific manuscript in my most recent role as a professor at University at Albany, State University of New York. And I'm excited about the tool because I think it's a really great example of a tool that is based on science, that is open access, but it's also designed for real world use in the field. So some of you may be familiar with the original model, and Space Tool 2.0, which we just released in February, uses very similar scientific methods as the original model, but it has several improvements. The first is that its parameters and methods are updated to incorporate the most recent scientific evidence. Second, we redesigned the interface to be more user-friendly. And the third is that we added new functionalities that would meet the information needs of users. And I'll explain this a little bit more when I give the tour of the model. So what is new with the underlying methods? So as Harold mentioned before, the original model as well was always based in science, so is this one. But we updated the methods to rely on a more recent study that evaluated the impact of federal STI funding on rates of gonorrhea and chlamydia at the state level based on 35 years of historical data. The second change is that we adjusted the methods so that you do not need to collect as much information to customize the model to your setting. And that was a deliberate choice on our part based on feedback from our users. Third, we updated the model to include the most recent estimates of direct medical costs for each infection. So that's part of just updating the science behind the model. And then finally, we made several other scientific improvements, such as updates to the confidence intervals. But what excites me a lot about this tool is that in addition to updating the science, which is important for the model's credibility, we also incorporated user feedback throughout the model's development. And it was really important to us as developers that the tool be both useful for public health practice and easy to use, not just based on good science. So important changes that we made based on user feedback was a more user-friendly interface. We added some new functionalities such as interactive charts, and we also added plain language interpretations throughout the spreadsheet. And we also did some extensive usability testing to make sure that the user experience would be strong. So now that you know a little bit about the model, I want to dive in and give you a tour of what Space Tool 2.0 looks like. So Space Tool 2.0 is downloadable, it's open access, and you can get it from the CDC website. And at the end of the webinar, we'll give you the web links on where you can access it. And this screenshot here shows you what the model homepage looks like. And so you can see a cute little logo. As Harold mentioned, we did a rebrand on this to really be much more inclusive and anti-racist with this particular tool. You can see that there's contact information in terms of who to contact for additional help. And you can also see that the spreadsheet pages are set up to help users naturally transition between the different screens as they do their work. So in this screenshot, you'll see, it doesn't come up on my computer screen very well, unfortunately, but there are different tabs at the bottom for Start, User Interface, Advanced Options, Model Overview, and Model Parameters. And that is really the places where a user might do their work. But within the model, there are also buttons to help direct users across the different screens. And the other thing that you might notice here is that we have this big yellow arrow with instructions. Here is sort of an arrow giving instructions on how to save the model. And we added these instructions throughout based on our usability testing and seen common places where our users needed a little bit of help and had some questions. So we really, again, try to make this tool as easy and self-directed as possible. So if you were to click that click to begin button on the start menu, you will come to this main user interface, which is what you see here. So this is blank. This is exactly what it will look like if you open up the model. And this is a really simple design. So this includes both the inputs that you will type in as a user, as well as the outputs and the what you'll learn from the model. And based on our user feedback, we intentionally kept this design layout really simple so that you can do all of your work on the same screen and it's easy to see what you're doing. So as a user, the only thing that you need to do is to enter the information for your jurisdiction on those cells on the top left corner. So what you need is your total population served, the number of reported cases of each STI in the past year, last year's annual funding amount, and your anticipated future annual funding amount that you want to model. And if you ever want any information on what these inputs mean, you can see the cells have some eye icons and you can click those and get a pop-up box with a little bit more information so that you understand, like, I reported number of chlamydia cases, you know, what's the definition of that and how would you know that from some of your data? As Harold mentioned, the Space Tool 2.0 is most suitable for smaller, medium relative changes in the budget, as well as for states and large cities. So after you enter information about your jurisdiction in those cells on the left, you'll see your results. So Space Tool will automatically do all of the calculations for you. All you need to do is to enter your jurisdiction's data. And on this main page, what you'll see is that the results are provided in terms of a 3-year impact as the default. And we picked that because it's a common time horizon for presenting results to policymakers. We have a box at the top, which provides the bottom line numbers in terms of total infections averted and total direct medical costs saved. So that's across all of the different infections. Inside the box at the top, you'll see a sentence with an interpretation that you can copy and paste and use in your own materials. So here it talks, the interpretation is that the increase in your annual funding will avert 2009 infections and save $906,000 in direct medical costs over the next 3 years. So we wrote that interpretation specifically so that you can use that directly in your materials. And then you'll see a table at the bottom, and that breaks down that same information down by infection. So if you're interested in knowing how does that break down in terms of chlamydia, gonorrhea, syphilis, you can see that in the bottom box. And you'll also have confidence intervals, which are represented as the lower and upper bound. And as I noted earlier, you'll see lots of yellow arrows here with instructions to help users navigate the tool in case they have questions or are feeling stuck on something. So my first example was the case of a budget increase, but you might want to be interested in what happens if your funding is going to drop. So if you enter a value for your anticipated budget that is lower than the previous funding level, you'll see that the interpretation in the text and tables will change from infections averted and costs saved to additional infections and additional costs. And so we built that feature into the tool that would automatically change in terms of the interpretation for you. So to clarify what this output means, Space Tool does not predict future STI rates or future costs. Instead, what it says is that for budget increases or decreases, Space Tool predicts how much lower or higher STI rates would be compared to what they would be under the current budget. So in our last example, that means that the $300,000 budget decrease would lead to 3,200 additional infections and 1.47 million additional direct medical costs over the next 3 years, compared to the expected number of infections and costs under the current funding amount. So going back to the model features, there are 3 buttons on that main user interface. The first button will take you to the advanced options page where you can add more customization, and I'll show that to you next. The second button will take you to the model overview page, which is where you can learn more about the underlying methods. And then the third button lets you print the page as a meeting handout. So that seems very simple, but that feature was requested by our users, so we made sure to integrate that into the new tool. So I seem to be missing a slide. Okay, so the main interface is going to give you the bottom line results, and we deliberately kept it simple so that anyone can play with it regardless of their Excel skill level. But you might want to look at a different time horizon or dig into the results by infection or create some customized charts to copy into a PowerPoint presentation or infographic. So if you click that advanced options button, you'll come to this screen. And this is where you can add more customization and do some additional explorations. And there are several things that you can do in this advanced options tab. So you can explore infections and averted and cost saved for different numbers of years. So maybe you don't want to look for at 3 years, maybe you want to look at 10 years, you can do that. There are tables and charts that examine specific infections. There's an interactive feature where you can click on these different filters to change the time frame on the tables and charts. And you can also export your tables and charts to another application so that you can use it in presentations and documents. And this slide here shows you just 4 examples of the types of charts and tables that you can create and customize in this advanced options spreadsheet. So here we have charts that show the number of infections averted and cost saved for chlamydia, gonorrhea, and syphilis. And at the bottom right, we have a table for STI attributable HIV infections. And one thing just to highlight here is that the time frame on all of these charts and tables can be changed. So that's why I gave you some examples here. And if you want to change the title, the colors, the labels, something to match your own theme from your health department, for example, you can also easily do that because you can export all of these charts and tables. Another important piece of feedback that users gave us was that they really need to be able to explain how the model works, right? So it's not just enough to be able to say what the bottom line number is, but they also have to be able to explain to their policy audience or their executives, how does this thing work and what does it do? And they really prefer to have all of the information within the tool rather than having to read multiple separate documents. So we devoted 2 tabs in Space Tool 2.0 to an explanation of the model and all of the different parameters used in the calculations. So we also have all of the citations there. In addition to all of the technical details, we created a simple 3-sentence summary that you can use in your own presentations and reports. So feel free to plagiarize, copy and paste it. We really try to make it accessible and something that you'd be able to use. And if you want to know even more details about the science or the model development process, we have a peer-reviewed article that is open access, so you can access that. And we also developed a video and handout on how to use the model, which are available on JPHMP Direct. So I am now going to turn this over to my colleague, Dane Collins, who is also at CDC and was also part of the model development team, who is going to lead our panel.
Great. Thanks, Erica. Good day, everyone. As Erica said, with CDC, Division of STD Prevention Program Branch, and I am a public health advisor and analyst on the evaluation team. For this portion, we will hear from 3 leaders in the STI prevention world to learn how SpaceTool 2.0 can be used. So I'm joined today by Stephanie Arnold-Pang, who's the Senior Director of Government Relations and Programs at the National Coalition of STD Directors. Daniel Daltrey is the Program Chief for the HIV, STD, and Hepatitis C program in Vermont, and Katie McComber, the Director of the Bureau of HIV, STD programs in Michigan. And as a reminder, before we get into the panel discussion, if you have questions, either about anything presented thus far, or as we go through the panel, please put those in the Q&A, and we will address those right after the panel discussion. So we've developed some questions that we'd like to discuss as a group. So panelists, what excites you the most about SpaceTool 2.0?
I'm happy to go first. I think sadly, one thing we need to be excited about now, I guess in quotation marks, is documenting the impact to our programs on the rescission of the DIS supplemental. And that's not really something to get excited about it, but I do think it's an important present moment thing that we could all be using to sometimes showing the impact of a decision to senior leadership, people in other areas of the department, whether it's your communications team, whether it's other people that work in public health. I think it's a really good tool right now for that. We'll get to later on how you can flip the tool, like Erica said, instead of looking at the impact of the negative, start thinking about solutions and maybe showing how an investment in your STI program can maybe replace that loss from the DIS supplemental. And so we'll get to some of those details later.
I would just add, exciting as it is, I really think SpaceTool helps to show, much like Katie said, we all know what it's like to have money giveth and money taketh away. While Vermont was going through that process, SpaceTool was incredibly vital at showing with the depreciated investment of what would be happening in our program, what expected costs we would be looking at, but to also be able to turn around and educate and justify, while we are losing X amount of funds, why we needed to keep a core amount of disease investigation specialists. So this tool came along at a really critical time. I don't want to give away my answer to the next question, but this tool, it's amazing how time and time again, these tools are available at a critical moment. While we were defending and reorganizing our program, this tool, SpaceTool 2.0, was released, and it helped us to seamlessly illustrate to our internal leaders at the Department of Health what we needed to have as a core and where we needed to bring other funding from in order to support our base of operations. So incredibly timely and helpful. In the end, while we build up to being a robust program of 9 DIS, at the end of the day, we ended net positive. Before the supplemental funds, we had 1 DIS. After the supplemental funds, we now have 2 DIS. SpaceTool helped us to justify the investment in creating more than 1 DIS for the whole state of Vermont.
And I'd just say from my perspective at the national level, I've not used it for programmatic interventions the same way Katie and Daniel have. But I was involved in this tool back in its release in 2017, and I was really excited at that time, for giving this tool being able to provide our membership with tools, with action, with numbers to support decisions and to provide that extra tool and numbers for education. And so I'm really excited about still seeing the functionality that I really enjoyed from 2017, the ease of use, the instructions in the tool, right? So often with some tools, it's like this like have a form here, and what am I taking from where, but having everything in one place, easy to use instructions to follow. I'm really excited to see that that's continued, and then obviously the updating the science so it's relevant, and you could say that, oh, you could still say it's an updated tool as opposed to a tool from 2017, which could argue against your numbers, but that it's up to date and that it's more current. So I'm excited about that as well.
Great. Well, thank you all. Very thorough, thoughtful responses. And some of you touched on the second question, which is that, the original Space Tool 1.0 was developed and released, as we've talked about, in 2017. So talk a little bit more, if you would, about how you've used the tool in the past with both internal and external audiences, and what was the process like, and what were some of the outcomes?
Dane, if I could jump in on that.
Sure.
So even before Space Tool 1.0, there was this fangled thing that I learned about thanks to Kevin O'Connor and Dane Collins and Harold, called STIC. And STIC really helped to model kind of the impact of what happened of DIS, Disease Intervention Specialist Services, being leveraged, looking at key indicators of performance outcomes and what those indices mean ultimately in terms of financial impacts and overall health. Again, estimates of what was going on when you looked at a productive workforce. STIC was critical for internal use and helping to show to some of the DIS, hey, this is what we do when we do the job right, when we do the job well, here's what's happening in a bigger picture. But something with that was missing. STIC alone wasn't helping me to educate my state epidemiologist or our health commissioner about all that was necessarily involved. So Space Tool 1.0 was an incredible supplement to STIC. When we compared the two together, when we began to look at the overall impact of DIS services, and what is the return on investment? Sorry to use the crude business term, but ultimately what was happening on the return of investment in DIS services, and also showing even without DIS services, what we would expect to see if the funding changed to this or that. I loved it at the time, though it gave me a bit of nightmares. I'm a bit of a Luddite. I don't adapt to tools well. Space Tool 1.0, as I said earlier, was incredibly helpful for me at the time when we had the windfall of the supplemental funds to show, hey, if we bring in 9 DIS, this is what we could expect to see. With these funds and this performance, here's what we could do. Now, pulling this information out of Space Tool 1.0, it was a godsend. I was grateful, but it was clunky, time consuming. I had to go back and keep checking. It wasn't necessarily intuitive. And as Stephanie alluded to earlier, it was a bit outdated. It helped. We ultimately got to bring in 9 positions, and it was incredible. But I don't think it was Space Tool 2.0. It might have happened to be a national pandemic more so that we had going on at the time. It was useful, but we still needed something more. And I think that's what we got at here with Space Tool 2.0. Sorry to be a little long-winded there.
Yeah, and I would just add to that, for Space 1.0, Space Tool 1.0, we didn't use that tool per se, but many, many years ago, used the underlying data that fed into that tool to create educational documents when we had a significant general fund ask in Michigan. I would just really advocate for combining space tool data with geographic data. I think that's a really effective message when people understand mortality and morbidity by geography. That's been very effective in Michigan.
Great, thanks, Katie. Daniel? Stephanie, anything to add to that?
Nope, I think Katie and Daniel covered it.
Great. Okay, thanks. On to the next question. STI rates continue to increase, and there certainly have been recent funding challenges, as you guys have alluded to. This is an opportune time for the release of Space Tool 2.0. So you talk a little bit more, you've touched on it, but talk a little bit about how you plan on using Space Tool 2.0 going forward.
Sure, I can start here. And I'm very, very lucky in Michigan that we braid STI funding with a wide variety of both direct financial resources and in-kind sort of human resources across general fund, Ryan White rebate, preventative block grant, even some of the most recent FIG, CDC FIG funding. But the key thing to sustaining our STI, especially DIS workforce, I think is Ryan White rebate. I don't know how many states here today don't receive any Ryan White rebate funding for your DIS. In general, we have between 10 and 20% of all of our positions blend funding. So I actually did an example for this question and sort of took out what would be the impact, not even on gonorrhea and chlamydia or syphilis, but just on STI attributable HIV infections. If we removed the current amount of Ryan White rebate that we're funding in our program out, and it is really significant. And I think we all can agree that the STI attributable HIV infections are really the minimum number that you can confidently say in the model. I think everyone would agree that probably the model is a conservative end of that estimate, and that the total prevention of HIV, whether you're looking at treatment as prevention, re-engaging people through day-to-day care, STI programs do a variety of things to impact HIV, treatment and viral suppression. So we did that. And so I did that model, and, just by investing a simple 1.5 million in Ryan White rebate funding. Now, Michigan is a bigger state. So I know some states would have a lower amount of that, but by just a $1.5 million investment over a 10-year period, we were looking at over $8 million in just STI attributable HIV infections. That doesn't even include any impacts to syphilis, gonorrhea, chlamydia, and many inverted infections. So I think if anyone here would like to talk about that strategy afterwards, I'm always happy to talk to people, but I just wanted to give that as a specific example of a sort of strategic way you could think about the tool.
Great, thanks, Katie.
And I think some of the how I'd answer this question is, to kind of echo some of the kind of the opportunity that Katie outlined for this tool, and that my job is to do advocacy on behalf of STI programs in the STI field, and having this type of data to be able to back up requests and your asks with numbers, because it's one thing to say STIs cost our health department or health system X amount of money every year, and that is backed up by science as well. But I think sometimes when I engage with public officials, their eyes kind of glaze over. But to be able to have something that is backed up by science for an individual jurisdiction, and to be able to do planning and to show projections, either positive or negative, I think that it's really important to have these types of advocacy tools, either with internal education within your departments for asks at a health department level, or to be able to bring them to policymakers, or to provide a tool to your partners, right? To engage the partners that could maybe do advocacy that I know state health departments aren't allowed to do. So it's really great to have a tool that is flexible and is designed for project planning, but can be used in many other instances as well.
And I would just close this out by saying, in terms of an application of this tool, I alluded to this in my first response, but part of what we were able to do, while we knew things had to change as guided by our supplemental funding being removed, we were able to show and illustrate what kind of investment we needed for a core operation, but also looking at our programming on the Ryan White side of the house, as well as our CDC HIV prevention funds, and how we could be bringing in some of those funds to support our work in our core DIS in order to avert potential cases that could be out there. As Katie mentioned at the beginning of this answer, if we look at HIV case rates and what could happen with the change of our DIS, we aren't maybe even in this model fully capturing all that DIS do, from leveraging, promoting, linking individuals to HIV PrEP, as well as Mpox vaccine opportunities. The investment in DIS really goes a long way. This model gives a really good core base of why an investment should happen. It's an incredible education tool and helped us to preserve at least 2 positions in Vermont.
Great. Thank you all. Thank you all. The last question for the panel today. What advice would you have for colleagues who want to use this tool?
I'll start by just saying, I think many of us have really been on a lot of national calls. We've been on calls with each other talking about the rescission of the DIS supplemental. Maybe many of us have sent an email to people higher than us, to people that, and sort of just said, this happened. But I do think, without saying, and so what, it's really hard for sort of senior leadership to understand, what opportunities or barriers there are. So I really encourage folks to use, especially with DIS supplemental, or if you're facing any other, reductions in your program, to just document in a memo, what the significant loss is here. And, talk to folks about the variety of funding that other folks get in their STI program as a conversation starter. There is a lot of money out there that could be leveraged that hasn't traditionally been leveraged, whether that's the block grant, Title V, Medicaid match dollars, just thinking creatively about what you could put in the memo. The second thing I would really do is to think about, again, opioid settlement dollars. There's opportunities there that I think traditionally we haven't talked a lot. So I'll stop there for a second and turn it over to Dan.
I love, I'm like writing vigorously notes here, Katie, as you speak. Like, I love the applications that you talk about, and we all, I think, could benefit from doing as you suggest. I also, there's another piece of me. Again, I want to go back to DIS, and just as you're working with your team of DIS, helping to show part of what their work goes towards. And, if we're able to procure more dollars for your services, look at the impact overall that this could have. It goes a long way, I have found, with DIS in helping to let them know and see the overall benefit of their service. The other application, I want to be supplemental to what you've offered here, Katie. The other place that I've really found a good impact of illustrating this is by going to our integrated community advisory group throughout the state, who, we tend to focus in Vermont, in our community advisory group meeting, we tend to focus on HIV prevention, as well as hepatitis C care and prevention. This was a great activity in terms of sharing and continuing to look at what we were seeing in terms of the impact of investment in STIs, and illustrating to this planning body in Vermont of the fallout and implications. So it's a really handy tool. Know this tool, use this tool. It really can help educate a lot of broad constituency.
The only thing I'd add, is that I would love to see more in engagement with partners as well, and and be able to provide tools to partners in state and local jurisdictions to advocate for funding that health departments can't advocate for, to see a diversified funding stream for maybe either local entities that don't currently put in money to their STD budgets, or states. And being able to, as I mentioned in my previous comments, be able to provide this tool to partners to say, look what this investment, a positive investment, could mean for our STI rates. Particularly, we're talking about syphilis or congenital syphilis prevention, because unfortunately all are aware of what those rates have done. And it is unfortunately, we've gotten to the point where we're finally it's fortunately that we're breaking through on the people not knowing or caring as much about STI, the impacts. But I think being able to provide, folks are finally becoming appalled at the congenital syphilis rates we have across the country, and being able to note what investments could do to these rates is really helpful for partners who can do, like I said, the advocacy that many of you all cannot. It's another tool for those partners as a conversation starter. Oh, Jane, I think you're muted.
You're right. Thank you. Great advice and some really creative uses. So before we move on to the Q&A portion of today, any final comments, Katie, Stephanie, or Daniel? Thoughts or comments? Anything that you haven't shared that you'd like to?
No, but I'll put my contact information in the chat, and anyone is welcome to contact me if they have any follow-up questions.
That'd be great. Yeah, if all three of you could do that, that'd be wonderful. Great. Okay, let's shift gears a bit here. Thank you again, panelists. Let's shift gears a little bit to open it up to questions that you've put in the chat. It looks like there's about 15 or so questions there. We will do our best to get through all of them. Any questions that we don't get to when we send out materials like the recording and the slides and so forth, we will create a Q&A document. So we can't get to them today. Please don't fret, we will. And as we go through these questions, if you have additional ones in the remaining 15 minutes or so, please put those in the Q&A or in the chat as well. Why don't we start from the top? And we've been joined back by Dr. Chesson and Martin as they have the overwhelming majority of technical expertise on the tool. So the first question is, to clarify, the tool predicts the increase or decrease in number of cases based upon funding changes, assuming local rates are unchanged from year to year. Basically a yes, no with maybe some caveats.
So we might need a little clarification on the question, but if I'm interpreting, you're saying maybe the question is, if you go back to Erica's slide about how to interpret the results, it's not necessarily saying that an increase in funding will cause a decrease in rates. It's just that the rates will be X amount lower than what they would have been. So maybe what this point is saying is, if you were to assume that rates would be unchanged in the absence of a funding change, like if you assume constant rates, then the tool could be interpreted as saying this would be the change in rates in the future. So I think that's a reasonable interpretation if I am interpreting the question correctly.
Great, thank you, Harold. If that answer did not suffice, or you had, please put another question in the chat. Can you create exportable reports?
I'll answer that as yes and no with caveats. So what we did in the tool, the screen that I showed you with the different visualizations, and so that's from a screen where you can look at these different charts and tables. And what we did is we unlocked that screen and we made a lot of things available to you, and so that you can change them a bit in the tool, and then you can copy and paste it into another application so that you can then further modify it. And so one thing that we have in the training materials that we made is we made a video on how you can do all of those functions.
Great, thank you, Erica. Next question. Does it explain somewhere how STI attributable HIV infections is calculated? Yes, it does, but Harold, do you want to?
Yes, we provide the sources for these in the main manuscript, but basically it's based on some complicated mathematical models, but we apply a simplified characterization of those models. We assume that for each STI, there's a very, very small chance that an STI attributable HIV infection will result. It's something like 1 in 5,000 for chlamydia cases and maybe 1 in 500 for syphilis infections. So that's how those are calculated in the tool. Like for each gonococcal infection averted, there's a very slight chance that there'll be a gonorrhea attributable HIV infection averted.
Thank you. Next question. Where do we get the numbers for the funding? Is it specific funding for STI, or is it equal to the organization's total budget?
For this tool, we need to use the STI specific funding because the studies that informed the tool were based on the amounts of STI specific funding that states were given. There is some evidence that general public health funding does have an impact on STD rates as well, but we don't have a tool for that purpose yet.
Thank you. Population served is the jurisdiction, for example, city, state, whatever, correct? Not just the number of people in a particular clinic. And rates would also be from the entire jurisdiction selected, correct?
That's correct. It's for the entire jurisdiction. If you're a state, then you would use your state population and your state number of reported cases, and same if you're a large city.
Great. Is it okay to use inflation adjusted dollars, or would you not recommend that? Some of our funding has stayed the same over the last 4 years, and we were hoping to still show the impact as those dollars are not equivalent due to inflation.
Right. The tool right now is set up to use $2022. So I think if you use unadjusted dollars right now, we're still okay. Even though we had inflation, the result should still be fairly reasonable. If you do want to take the trouble of using inflation adjusted dollars, you would adjust them to $2022 and enter them in the tool. And hopefully maybe in the future, we can post guidance on the website about how to adjust for inflation.
Great, thank you. These next two are kind of lengthy, so you need it repeated. I have a state budget which focuses on syphilis disease intervention with other funding on a local tribal health department level, which focuses on chlamydia and gonorrhea. Would this work with just focusing on the budget which focuses on syphilis? Or would we need to get all of the different local and tribal health department budget as well?
That's a tough question. One of the limitations of the tool is that it's even though it's based on 35 years of state level data, what it does is it represents the average effective funding for the average state. And some states might devote more funding to, say, gonorrhea than other states, which might focus more on syphilis and so forth. So if you have certain parts of the budget that are allocated to syphilis and other parts that are allocated to chlamydia or gonorrhea, I think the most conservative approach would be to just examine your total level of funding for your jurisdiction and look at what predictions say for the 3 STIs, and understand that in certain areas where you focus on syphilis, then the number of syphilis infections averted might be greater than what the tool is estimating, and vice versa.
Okay, thank you, Harold. I understand the purpose of SPACE is to show the impact of budget allocation changes. But I would like to show public health partners the medical and social cost savings resulting from lower early and congenital syphilis morbidity. Does SPACE provide such information? If not, are the economic assumptions viewable to calculate such costs?
Unfortunately, we don't include congenital syphilis in the SPACE tool. The reason is that we have studies that show a link between prevention funding and STI rates, but we don't have that specific link to preventing congenital syphilis, although it seems, quite clear that if you prevent syphilis, you will be preventing congenital syphilis. To look at this, what I would recommend that you could use the stick figure tool, which Daniel mentioned earlier, because that allows you specifically to enter information about the number of women that you treat for syphilis. And right now we are updating the stick figure tool, but the old version of the tool is still out there and available. And hopefully within the next year or two, we'll have a update of the stick figure tool.
Thank you. Is there a way for local health departments with DIS to look at Ryan White funding, even if the state STI program isn't requesting this funding?
I mean, I would advocate putting it out there, and also don't stop there. As Katie alluded to, looking at other partners within your Department of Health that receive SAMHSA funding, looking at reproductive health funding that may come into your Department of Health and other programs as well. There are multiple partners that should see these data sets and outcomes, just to let them know the impacts that the funding is having and a role that they could prospectively play in helping to address the sequelae related to STIs.
Thank you. I've never used SPACE before. Is there a function where we can calculate the cost efficiency of prevention funding? In other words, DIS FTE cost X amount of money over time, but comparatively aiding with medication for a person living with HIV costs Y amount over time.
I don't think the SPACE tool would be helpful for doing specific cost efficiency studies, like trying to figure out, is the DIS FTE, worth it or not. But the SPACE tool can give you fairly simple comparisons. For example, when you enter in the amount of the budget change, say a budget increase, it will tell you the averted medical cost. So it kind of gives you that. And in many cases, if you have a reasonably high burden of STDs in your jurisdiction, then the tool predicts that the averted medical costs are usually greater than the additional funding needed to achieve those reductions. So in many ways, it does demonstrate efficiency of prevention activities, but just on a more widespread scale and not looking at specific prevention activities.
Great, thank you for that.
And I think I'll just add as model developers. So I think Harold initially in his opening remarks made a good point about this is really based on the science. And so we wanted also as developers to be really clear about what we're doing. So although the tool can't always do all of these different things, I think the panelists talked about some really great ways that you can adapt the language and what you're finding to illustrate different points.
Great. Thank you, Erica. ELC funding under SetNet should be considered for congenital syphilis work. Arkansas presented their work on CS cases averted recently. Why are more states with abundant ELC funding not considering including STD, STI control concerns in the ELC application or reapplication?
I might be able to speak to that.
Sure.
There are, at least right now, in what Michigan is eligible, is we have 3 pretty significant funding streams coming into our STI program from the ELC funds. But I was talking to one of my equivalents the other day from a different state who had no idea that there was a new HIV CDR subcomponent in ELC release because no one from the ELC group told them that it was there. So SATNet does include syphilis. We have syphilis in Michigan for SATNet and our participates in that. ELC does not release money that is really flexible to allocate. So ELC is not just going to say, oh, we're going to give you $1 gazillion and you can choose to send some of it to HIV or STI. In general, it's very project specific, but there are at least 2 or 3 specific projects. And if your state is eligible for those, I would really encourage folks to develop an ongoing relationship where you really check in with them every year when the NOFO is released.
Great, thanks, Katie. Any other thoughts on ELC funding under SETNet? Okay, it looks like we have one more question, and we're about out of time. So looks like a great tool. I will have more questions when I use it. Who should I contact for questions at CDC? And I would say technical questions, anything about the tool, Doctors Chesson and Martin would be your best points of contact. And their contact information will be in the slides that we send out. And we also can add it to any kind of Q&A document that we send as well. So at this point, and I see a couple people ask for the link to stick figure, and I think somebody kindly enough put that in the chat. So thank you for doing that. And now I will pass it back to Erica.
Great, and I appreciated the question about it's always hard to run the screen. I appreciated the last question because it really segued into our wrap up. So how do you get started? So thank you everyone just for your participation and staying engaged. Hopefully you'll be as excited about the tool as we are. So here's the links. So how to access the tool on CDC's website. We have supplemental materials. So we already have a training video there and a handout just to get you started. We have a blog that explains this all in plain language. We'll be putting this webinar recording as well. And we also have a link here to the scientific manuscript that also includes a very, very lengthy technical appendix with anything you ever wanted to know. Don't worry about memorizing all of this because we will be sending out these slides after this presentation. So when we're done, within a few days, we'll send out answers to any questions that we didn't yet respond to. You could contact me or Harold. I just listed Harold's contact information here to be less confusing, but his contact information is also available in the downloadable tool as well. So with that, thank you so much, everyone, for your participation. We're excited to have you here. If you have any further questions or comments, please do not hesitate to reach out to us. And we'd also just really love to hear about how you've been using the model in your own work. And stay tuned for Stick Figure 2.0, which should hopefully be out within the next year. So thank you so much.